are very excited to hear a lecture from Dr. Jeffrey Stovall and then have some time for question and answers. Dr. Jeffrey Stovall is an associate professor of psychiatry at Vanderbilt University Medical Center in Nashville, Tennessee, in the United States. Dr. Stovall works in community psychiatry and in primary medical settings with an emphasis on serious mental illness, the integration of psychiatric and medical care, and cross-cultural psychiatry. So we're very excited to have him here, and without any further ado, Dr. Stovall.
I want to thank everyone for inviting me to participate in this lecture tonight, and look forward to hearing your responses and questions after a brief presentation. Maybe we could see the next slide. I teach here every year a course in global mental health, and my students struggle with kind of understanding what that means. I think we're now in a period where we see the global effects of many illnesses, and tonight we want to focus a little bit upon those from a psychiatric and mental health point of view, but I think this is bringing it all home to us in terms of the global experiences. We can look at the next slide. So I want to talk a little bit about those individuals who we know are at increased risk of being infected with COVID-19, and then talk a little bit about how that ties into the mental illness and the effects upon mental health. And one of the things we know is that individuals with pre-existing mental illness are at particularly high risk. That includes the elderly, those with lowered immune systems, and those living in crowded conditions or poverty. This also relates, and I want to spend a fair amount of time talking about those who work in those communities, and that will relate to our discussions around healthcare providers and physicians and clinicians in these settings. We can look at the next slide. So what do we know? What do we know about patients, individuals who are infected with COVID-19? Obviously, we're learning a lot as we go about this, and some of the information that we have is based on preliminary studies and reviews of individuals infected, as well as what we've learned from other coronavirus infections in the past. But one of the mental health consequences we look at is related to the direct impact upon the brain or consequences of treatment. So for people who are currently infected, one of the things we see is a high rate of delirium. Those of you who are working in hospital settings, I'm sure are seeing this, where up to 2/3 of those, 65% of those who are hospitalized experience a period of delirium, either at presentation or more likely during the course of the illness and during the course of treatment. We're also learning a lot about the effects upon clotting and cerebrovascular disease that can develop through COVID infection. And again, we're seeing that in terms of psychiatric and neurologic manifestations. And most patients have at presentation or early in the course of the illness what we would consider to be milder neurologic dysfunction related to the infection. Headaches, dizziness, some cognitive dulling or cognitive blurring is common early on. Next slide, please. What we're just trying to understand and get a clear picture of is what are the effects of the psychological impact of the illness. Immediately or more clearly, what we're now learning about is the effect after the course of the illness or through the course of the illness. Again, those long-term studies with COVID are preliminary at best, and we extrapolate a lot from what we understand from previous coronavirus infections. But certainly in those, we saw a prolonged experience of depression following the initial infection, up to 29%, well over a quarter of patients. Still at 1 year, we're experiencing symptoms consistent with a depressive episode. A third of patients or individuals were still experiencing significant anxiety at 1 year. And again, a third of individuals met criteria for post-traumatic stress disorder. So significant anxiety with significant functional impairment up to 1 year later on. One of the things, again, that is clear is that cognitive impairment, even in these preliminary reviews of patients infected with COVID, the cognitive impairment is persisting after other manifestations of the illness may resolve. So declines in memory, impairment in attention, impairment in concentration, impairment in processing, mental processing speed. So again, significant impairments cognitively that persist. We don't know how long that persists. We don't know those long-term effects. But clearly something we're seeing early on at this point. Next slide, please. So what about for individuals living in the community who may not be as directly affected by the virus, may not be infected by the virus? One of the things that we're seeing throughout communities is the impact upon social isolation, as in around the world, people are asked to shelter in place or be quarantined or to remain at home. And we know that upwards of about half of those individuals who are sheltering in place are reporting adverse mental health effects, particularly around the effects of loneliness, depending on how isolated a person may be, but the impact of depression and anxiety in particular. Again, occurring around the world is the economic impact upon people. And again, as we all know, the significant mental health impact of job loss, again, around depression, anxiety, increased risks of suicide, and as I'll speak a little bit about later, the increased risk of substance use following adverse economic impacts and particularly job loss. And this is something that's been well shown in a variety of studies over the years. Next slide, please. So what can we do about this? Clearly, the broader societal and economic issues are beyond the scope of what we as physicians can tackle, but certainly something that we can educate ourselves, our communities, and our patients about, and advocate for that as we help healthcare systems and our societies react to and adjust to the impact of COVID. So around increasing awareness of the mental health aspects of COVID-19, being prepared or advocating for access to and initiation of prompt treatment, where in particular, again, depression and anxiety are problematic. And as we're doing tonight, taking a lead role in terms of education for our colleagues and for healthcare systems more broadly. Next slide, please. So what about consequences for individuals with pre-existing mental illness? Again, individuals who have pre-existing depression, anxiety, trauma-related illnesses, or more severe mental illnesses like psychotic disorders, schizophrenia, and bipolar illness, we would expect significant relapses. Certainly what I'm seeing in my community, in my practice, is a lack of access to care. So individuals who may have a chronic illness that's generally well treated, but are no longer coming to the clinic, can no longer access the medications that they normally have access to. That may be for financial reasons, it may be because they are staying at home as they're asked to do, but with a significant disconnect from their ongoing treatment. We would expect high rates of relapse, and certainly seeing high rates of relapse among those individuals. People with pre-existing addictions, we're seeing significant increases in relapses. So individuals who may have had an alcohol dependence that's been well controlled for some period of time, under the periods of stress, again, with poor access to care, the loss of economic and social support that they rely upon, are much more likely to relapse on alcohol or other drugs. And again, we're seeing that with individuals with depression, with psychotic disorders, and anxiety disorders. One population among this is for individuals who've had significant trauma in the past. That may be trauma domestically in terms of their home life, their relationships, their marriages, or people who've had more communal trauma in terms of war or displacement in some way. Any subsequent trauma can trigger previous trauma responses. And again, we're seeing a marked increase in trauma-related symptoms like depression, anxiety, sleep disturbance. Next slide, please. So what can we do here? Again, awareness is part of it. I think as COVID-19 began to appear in communities and sweep the world, we clearly had to focus on the immediate medical consequences and medical risks. Now we're in a position of continuing to do that, but also seeing some of these longer term consequences among patients who seem to be less directly affected by the virus and COVID-19. So again, awareness and education is important, but being aware for our patients who have pre-existing psychiatric illnesses, mental illnesses, to be aware of the high risk of relapse, to be ready to initiate treatment, reconnect people to treatment, and even reach out to those individuals as we can to maintain treatment or reinitiate treatment as need be. Next slide, please. So let's focus a little bit on the consequences for clinical personnel working with patients with COVID-19. As you all well know, this has put an extraordinary burden upon physicians and other healthcare providers and clinicians working in these communities. For many people who are used to having adequate resources to do their clinical work, are finding themselves in positions of not having adequate resources. For people who are used to working with limited resources and perhaps treating high volumes of patients, that is being doubled and tripled. And so clinical personnel are not only at great risk of being infected through exposure, but also in bearing the consequences of what is often just an overwhelming demand upon the healthcare system. We're having a little preliminary data around this. There was a very strong study in China and Wuhan looking at individuals, healthcare providers on the front lines in the first month of the pandemic there. That showed significant rates of debilitating levels of symptoms of depression, approximately half, anxiety symptoms, again, almost half, sleep disturbance, about a third, and just an overall sense of distress that was leading to functional impairment in almost three quarters of those individuals. Of significance and can't quite fully understand this, those rates were much higher among women, which may be that women were more likely to be in even more frontline or direct care settings, and among those, again, with pre-existing illnesses or those with in more frontline roles. Next slide, please. So what have we learned before in other studies, either in widespread illnesses, or more commonly the studies have been done in other forms of disaster, really more natural disasters, earthquakes, and hurricanes in particular. There have been large studies, and some more warlike disasters. 9/11 in the United States, there have been a lot of studies looking at healthcare professionals in the time thereafter, and studies looking at individuals up to four years following a disaster, shows that those mental health consequences last. So up to 4 years after a disaster, up to a third of those healthcare providers will still be meeting criteria for depression. A third with significant symptoms of anxiety. Still a third with ongoing sleep problems and overall difficulties with cognition. Again, we see that difficulty with focus, concentration, mental speed of processing or processing speed as being a recurring and long-lasting effect post-disaster, post kind of frontline clinical work. Next slide, please. So what can we do about that? I think, again, an important part of all this is just awareness of knowing that this is a risk of the work that we are doing or that we know our colleagues are doing in the healthcare systems. Treatment is important, and I'll talk about treatment in a minute, but there are specific treatments that can be useful. This can be a very stigmatizing thing. I think many of us in healthcare approach it or are seen as being invincible to the stress, if you will, of our work, and recognizing that this is significant, can have an effect, and it's widespread, and so it's not a sign of our own weakness, our own failures as physicians or healthcare providers, but rather it's a risk of the job at the moment. Self-care, taking care of oneself, taking care of one's team to the degree that we can work with others and take care of each other can have a huge impact, positive impact. And that may seem impossible in the midst of a long day, a long week, a long month. But in order to sustain this work and to survive this work, that self-care is important. And advocacy, again, as physicians, we often have the role of being able to speak a little bit more directly to healthcare systems or wider communities and advocating for care of ourselves or our colleagues. Next slide, please. So very specifically, what treatment do we know that can be effective for us as healthcare providers if we expect that 4 years from now, up to a third of healthcare providers will still be having long-term mental health effects from this? Well, what we've seen in other disasters and other crises is the importance of a return to normalcy. That's maybe most applicable when there's a natural disaster. There's an earthquake and communities rebuild and can go forward to some degree over time. To the degree that returning to normalcy with COVID-19, to the degree that that's still up in the air, that's still unknown, we may not be returning to normalcy anytime soon. The importance of existing social supports can't be understated. The role of family in terms of support, community at large, one's religious faith or other beliefs, the role of professional support and colleagues is really important. Again, something that's may not be as immediately available in the period where we're being encouraged to use physical distancing, social distancing, the ability to get access to those usual supports is more limited. For ourselves and for our colleagues, the importance of focusing on the risk of alcohol use in particular, but all sorts of drugs of abuse, and bearing in mind that alcohol doesn't heal. So if you think of some of the effects of the stress that I had mentioned, the anxiety, the poor sleep, just an overall sense of distress, you might imagine that for some people, increasing the use of alcohol can seem like an immediate relief, but we know that increases the risk of those longer term negative impacts. Immediately in the short term, the role of sleep for protection and healing can't be understated either. And again, that may seem difficult to do during times of longer shifts, working more, never being able to finish one's work, always having more patients to see. But this is the effective time for sleep medications of various sorts, practicing what we refer to as sleep hygiene, just taking care of ourselves for sleep. I'll provide some resources toward the end here with regard to some cognitive behavioral treatments for insomnia that may be accessible to people. So sleep, again, is an important thing. There are just effective treatments that we know can work for those who have persistent depression. As a group, healthcare providers tend to be undertreated when it comes to depression and anxiety, in part, again, related to those issues around stigma. But it's important for us as physicians, as healthcare providers, to know what's available to our patients, to know what formularies we have access to know what antidepressants may be available in our country or in our clinic. And there are a great variety. It's just a question of knowing what ones are available and learning how to use those or feeling comfortable using those. And then finally, more formal types of psychotherapy, of counseling can be effective. Again, I'm going to give some apps at the end of this or at the end of this that can be available to patients, to ourselves, even if we don't have access to more formal trained therapists and counselors. Next slide, please. So again, effective treatments are effective. And as we move forward in educating ourselves, assisting our colleagues and ourselves in treatment, knowing what's available, knowing the role that antidepressants can play when that depression and anxiety is persisting, short term, knowing what anxiolytic medications we might have available, that may be benzodiazepines in some settings, and maybe antihistamines in some settings. Again, knowing what's available and knowing and feeling comfortable how to use them. And then finally, the psychotherapy or cognitive behavioral therapy apps that will be available at the end here. Next slide, please. So there's just a couple of studies in particular. The third one is reference to the study done in Wuhan that looked at healthcare providers. That's particularly helpful, but all three of these may be of use. And then the final slide, I believe, is just some web-based resources that hopefully you'll be able to have access to. A couple of these or one or two of these. The first two are more specifically around sleep, and the next three are apps that individuals can use targeting anxiety and depression. So all three of those could be helpful. So that's my formal presentation. I really wanted to just set aside the majority of time to be available for y'all's questions and discussion as we go forward. Now, Jays, if we have some questions already posed.
Yes, well, thank you for that presentation. It was really great. We had a few questions come in during the registration process, so we can get started there. And then if anybody has any additional questions, please feel free to ask them in the chat box. But the first question is, during longer lockdowns and imposed isolation, how can agencies ensure MHPSS services to the most vulnerable children, adolescents, and women?
Yeah, so I think what we're clearly seeing is that when an entire community is isolated, there are some who are more isolated than others. And that traditional ways of reaching out to individuals may be limited. So those social groups that may typically reach out are going to be more isolated. Children who may typically be getting services or kind of have the opportunity to have interventions if they're not doing well in schools are not going to schools now. So in part, this may be that we're waiting for things to lift a little bit, and being aware that as individuals are able to be less isolated, children are going back to school, people are coming to the physician, returning to the workforce perhaps, to be aware that we're going to see difficulties that have been kind of hidden during the lockdown period. We may not be able to go in and make those interventions now outside of, internet access for individuals, but it may be more being aware of what's going to come soon as people are out more.
Thank you. The next question is, what is the extent of mental health problems in pregnant women or lactating mothers and children during this pandemic? And how can healthcare providers help relieve mental health problems in these populations?
Yeah, I know that one of the previous talks particularly looked at pregnancy, or one of the obstetricians gave a talk on that, and I think in terms of COVID-19, the immediate risks during pregnancy are not clear, but may not be as worrisome as initially thought. I think I would look at that as a population and individuals who already feel more vulnerable during pregnancy, just like other vulnerable groups, people with pre-existing illnesses, the elderly, who are going to have higher risks of anxiety because of their known vulnerability, or their expected vulnerability. So again, I think we're identifying populations to be particularly aware of as we work with them, providing education where that's possible, trying to do that sort of social outreach to the degree that's possible. Again, all these things are limited. In other situations, we would do that through really physical outreach, and that's much more difficult during times of social isolation. But where possible, identifying, knowing those populations are going to have higher consequences from the isolation could be helpful.
Great. A couple of questions have come in through the chat, so I'm going to jump over to those real fast. What are some specific examples of self-care that you might recommend for healthcare providers, keeping in mind some may have limited resources?
Sure. A lot of it may just be focusing on sleep. Some basics just don't happen when we feel overwhelmed. So trying to eat regularly, trying to sleep regularly, try to drink water regularly, avoiding those things that are problematic, too much caffeine, too much alcohol. Those kind of very basic things in self-care can go a long way. Trying to build into your day a few minutes of quiet. That may be quiet by simply stepping outside and taking some deep breaths. It may be some exercise. It may be listening to music. And it may seem like something that's totally impossible in the course of a long day. But a few minutes of that at the beginning of the day, at the end of the day, may go a long way toward helping one get through. And finally, I think as physicians in particular, it's easy to feel isolated from the rest of your healthcare team, if you will. We may feel like, as the physician, lots of other people are looking up to me, maybe more junior physicians, nursing staff, other healthcare providers. Everyone's kind of looking to me as the physician to be in charge, to be cool, to be calm, to be collected. And this may be one of those times where, while that's important to continue, it's also important to be a member of that team so that you can participate in that support, that collectively you all can acknowledge what you're going through and the importance of working together and supporting each other. Again, something that's not easy for physicians sometimes.
Thank you. How useful do you think it is to train healthcare workers on how to provide psychological first aid?
So it is extremely helpful. There are ways of kind of formal ways of training that. That said, I think even without adding one more layer of formal training right now, which many of us may feel like we don't have time for that, relying upon those basic empathic skills that as physicians, we hope most of us have anyway. Acknowledging and understanding these psychological impacts that COVID-19 is having upon our patients, is having upon their families, it can go a long way. That in and of itself can be a form of psychological first aid for our patients. And again, kind of thinking of ourselves and our teammates, that can go a long way. So again, breaking down that stigma, being honest about the impact psychologically can go a long way for ourselves and our patients.
Great. What are the psychiatric manifestations of COVID-19 in children and adolescents, and what are some ways of handling this?
Yeah, so at this point, the data is really pretty limited on is there a direct impact of the virus or the treatment. In some cases where in some of the earlier treatments where people may have been using steroids for respiratory disease, there have been manifestations of anxiety, mania, and psychosis. But in terms of at the moment, there aren't those direct effects beyond those few neurologic effects that I mentioned. Again, it's more these kind of longer term effects, either from isolation or from the longer term consequences of depression, anxiety, and some cognitive impairment. And that's more what we're seeing, whether it's in children, adolescents, or adults. I think one of the things that we don't know the long-term effects for children is going to be the significant disruption that came as schools closed down. So for many children, school has all sorts of functions beyond learning the textbooks in terms of socialization, learning those skills, and kind of overall mental well-being and mental development. And the longer this goes on, and in many communities, we don't know that long-term effect. And that'll be something we'll just have to be prepared to respond to and pay attention to in coming days.
Great. The next question is, do we have any data about effects of lockdown and quarantine on mental health in developed and developing countries?
We don't have data. I think the studies in that are yet to come. I think the impact that we will see is going to come down the road. That may be weeks and months down the road. Certainly, preliminary impressions are a significant increase in relapses among people who have pre-existing illnesses. And extrapolating from what we know from previous, particularly disasters, knowing that even individuals who hadn't previously had a psychiatric illness are going to have higher rates of depression and anxiety in particular. But we don't have any more community-wide studies yet looking at that.
Great. One question, a couple of actually questions that kind of go hand in hand. How can I tell if myself or some of my staff have burnout, and how can I take care of these people?
Sure. Probably reasonable to assume that most of us are having some degree of burnout. So if you start with the assumption that that it's there, you're probably going to recognize it pretty quickly. But common signs are kind of developing a lack of empathy, kind of beginning to feel like each patient is the same, kind of losing track of this individual versus that individual. Seeing that in our colleagues may be easier than seeing it ourselves. And again, when we talk about kind of taking care of a team and being part of a team, this may be something to talk about and have an environment with your teammates so that somebody can say to you, man, you look like you're going through the motions. You look like you're not caring. You're not really having an emotional or affective response to what's going on around you anymore. And that kind of emotional numbing can be a sign of burnout. Clearly, at its more extreme, again, it can be showing up in terms of not sleeping, having significant anxiety, feeling, frankly, more sad, or developing suicidal thoughts at their extreme. But I think in the short run, there's a combination of emotional blunting and cognitive blunting to pay attention to for ourselves, and then have other people to pay attention to for us. Again, I would expect and certainly have seen that some degree of burnout is going to be existing. And that's where, again, we looked at initially self-care and team care, but then ultimately for some individuals requiring more formal treatment if it becomes more pronounced.
Thank you. Another question that came in from the chat is, what are effective methods or the best approach to patients with severe addictions to drugs or alcohol in the context of COVID-19?
Yeah. So, as physicians, we know that prevention is always easier than treatment. And so certainly all of the patients that I see who have addictions, even people who feel like, hey, I've been doing really well for a long period of time, this is part of an ongoing conversation. This is part of outreach, whether it's by phone or Zoom visits or whatever ability you have to let people know that this is a risky time. And whatever that might be that has helped them stay abstinent, stay sober, is useful to be doing. So for some people that might be more formal treatments, that may be things like Alcoholics Anonymous if that's available, or for some individuals that may be medication assistant treatment for addictions, methadone, Suboxone, other forms of treatment. So again, knowing that this is a period of great risk, trying to identify with individuals what is it that has helped them stay sober or get sober in the past, so that they can be using those skills and reinforcing that now, and then be prepared to have more definitive treatment if need be, whether that's detoxification or where, if you have this available, longer term abstinence-based treatments like, say, methadone for opiate dependence.
Great. Has there been a significant increase in mental health issues among healthcare workers in regions that have been highly affected?
Yeah, very much so. And I think that's what that study in Wuhan showed, where individuals really in the midst of it, within the first month or so of facing the pandemic, are having significant rates, a third to a half of patients with depression, with anxiety, and the majority of healthcare providers feeling some level of distress. And that stress often then ends up translating into more formal diagnoses of depression and anxiety. So clearly we're seeing that early on. That study has not been replicated, but certainly there are people working on that now, and not surprisingly, we will see that across the board. Again, one thing that we saw in that study that'll be significant for us to all apply where we're working is that the closer to the front line an individual's working, the more likely they're going to have mental health consequences. The longer that exposure is, the more widespread within a community that COVID infections are. All those are going to increase the risk of an individual healthcare provider developing mental health problems. And finally, just always being aware that people who've had mental health problems in the past are much more likely to develop mental health problems again. So most psychiatric illnesses are potentially relapsing illnesses. This is a classic sort of time that could push individuals to relapse, whether it's depression or a more serious illness like bipolar illness.
Great, thank you for that. Another question that kind of ties in nicely to that, but what are the most common mental health problems in community and healthcare providers during the pandemic?
I think the most common thing that I've seen or heard people talk about is anxiety. I think we're all being told to be somewhat anxious, to be somewhat aware. We're all supposed to be vigilant. We're all supposed to wash our hands or wear masks or stay in our houses. So we're hearing in most of our communities, we're hearing stay anxious, stay alert, and that alertness can easily grow into an anxiety that's magnified. So it's when that little bit of healthy level of fear that we all are being instilled with now gets exaggerated, gets constant, and our fight or flight mechanisms stay stuck in this high level of anxiety all the time. So I think that anxiety is the most common thing, and probably connected to that are sleep disturbances. And then I think following that are becoming more frank depressive symptoms of sadness, hopelessness, withdrawal. Sleep disturbance can go along with that. And then suicidal thoughts that can be connected to depression.
Thank you. That leads well into this. Has there been an increase in suicide rates in areas that have been highly affected?
Yeah, there haven't been studies that have shown that either way. That's probably too early to tell. Again, we have seen in previous disasters that there are significant increases in suicide rates. That tends to play out over a period of time. So not so much days and weeks, but more months and a year or two thereafter. So some of the studies that looked at what are the consequences 4 years later. Again, those studies generally are done on smaller communities. One area that's where there's been a natural disaster. In New York, after 9/11, the studies of that small community. This is really sort of uncharted territory as it is a pandemic that is affecting individuals throughout the world. So it's somewhat uncharted territory, but based on what we know from previous disasters and the effects both upon healthcare providers as well as communities at large, we would expect that this would translate into higher rates of suicide.
Thank you. The next question is, what are your recommendations regarding the considerations that need to be in place in LMICs before setting up a mental health hotline?
So I think, you all know better than I what resources you have. So do you have individuals who are trained or have the skills to handle the questions, the distress, the calls that they would get? Do you have access, would those individuals have access to refer people who need more services? And do you have the way to help those individuals take care of themselves? So again, if you think about people who are on the front lines, those individuals who are manning, if you will, the hotline, are going to be quickly traumatized in their own work. And so do you have the ability to support those individuals in doing their work? We do know that in any periods of disaster and any periods of great stress, individuals having the ability to realize they're not the only one experiencing that can be extremely helpful. Again, due to the mandates of staying home, people's ability to connect to those natural supports is limited. So things like hotlines or internet access to other individuals could be incredibly important in feeling support and realizing I'm not the only one going through this. But again, we're in a unique time where that access to that may be more limited now.
Great. Another question from the chat. How would you recommend hospital administration adjust staffing procedures and schedule, if possible, to support healthcare workers during this time?
You know, those things that we know are good for us really are good for us. They're just not always possible. So giving people adequate time off is always important. Giving people days off is always important. Allowing people time to sleep and time to eat and time to go to the bathroom is really important. You all know your own facilities well enough to know to what degree is there that flexibility. Is your community in the midst of a time right now where that's just not possible, and then it's not possible? Or was it not possible a week ago, but now it may be getting to be more possible? I think one of the things I've observed and been told is that in many places, in many hospitals, in many communities, there was a quick ratcheting up of the anxiety and the preparation for a short-term disaster. And that's been necessary in many places. What we're seeing as a short-term disaster is transforming into a long-term level of alertness and pressure and demand. And that level of we're prepared right now for the disaster cannot be sustained over time. And so I think all of us individually and all of us as providers are trying to transform into, okay, this is a new level of alertness. We're doing things differently. My work, it may be different. Maybe we may get these waves of increased demand, but we can't maintain this crisis mode all the time. We have to be in the crisis mode during the crises, and then we have to be able to fluctuate that, if only for our own sanity, as well as the well-being of our healthcare systems. And I think lots of healthcare systems and lots of us have gotten stuck in that crisis mode when we may not need to be in that every single day or every single week.
Thank you. That's really very true, I think. Another question, do you have advice on how healthcare workers best deal with helplessness and grief from witnessing severely ill patients, especially when they have no family around them to support them?
Yeah, and I think, those of you all who are working kind of in the front lines or in the hospital settings in particular, are seeing that we have lost one of the things that may help individuals die, may help families grieve, which is being together. So the individual who's able to perhaps go home to die, or the family that's able to be there at bedside. And this has been a time where that's often not been possible. Even rituals following death have been disrupted. In the immediacy of death and the funerals and all the rituals that are important for us in grieving. And healthcare providers are often put even more so in that role of being the family, of being the one who is there, not only being the caretaker, but being the one who's kind of the go-between family and the patient. And that's not a role that most of us have spent a whole lot of time in, because usually there's family and others involved. So this is a new and much higher level of intensity than we are prepared for. Again, I go back to the value of working together as teams. If we think this is just me who's got to do all this, then we're not going to be able to do all this. We're not going to survive that. It's going to take its toll. We're going to burn out. We're going to get anxious. We're going to get depressed. Being able to, as best we can, share this among teams, have that place where after a patient's death, We can go aside by ourselves or with a teammate, and maybe it's cry, or maybe it's yell because we're mad, or maybe it's walking around the block. But it's something to acknowledge that this is true, that this really is happening, that we may not be prepared for this. This may not be what we're trained for. But that's part of that self-care as we go, and to some degree acknowledging when we may be asked to be doing superhuman things, that we are in fact human, and that this does take a toll on us. And then just because I'm a physician doesn't mean that I don't grieve too, or it's not painful for me to see this happening. That's not, again, something that's not always easy for us to do as physicians, or our teammates don't want to see us in that role, or aren't used to us in that role. So that's a tough balance for us all to have.
Great, thank you. I want to be aware of the time. I know we're coming to the end of the session, but just a couple of more questions before we do that. What would you say to healthcare workers who are either worried about possibly infecting family members, or family members who are worried because of their healthcare workers' exposure to COVID-19?
You know, I'm glad somebody asked that question, and I think that that's really key. I meant to mention that earlier. I think often that's been kind of an unspoken issue for physicians, for healthcare providers, and for their families. I know in my own family, my wife and other family members were reluctant early on to say anything to me about, gosh, should you be doing this? One of my sons, a week or two after my own hospital, sort of shifted how we were doing things, and I was kind of put in a different role than I usually am. I usually walk to work. I live relatively close to work. I usually walk to work. And one of my sons said, Dad, I really would like it if you would drive to work now. I don't want you to have that other risk of, you know, the 10 minutes of walking to work, the 15 minutes of walking to work. In fact, that was probably the safest part of my day. But it was important for me to hear that from him and respond to that. I now drive to work, and it makes me feel better. It makes my son feel better. But I think we have to be honest about that. I now dress differently at work. I go home and I take off my clothes as soon as I get home and wash them, and then change into my other clothes. My mother is 92 years old. She lives close to me. I have not. I've talked to her kind of through a window, but I don't see her. I don't see her in the same way. I don't hug her when I go to visit her. It has a toll on her. It has a toll on me. And this has now been going on for 3 months. And in reality, as healthcare providers, we are much more likely to become infected than others, and death rates and infection rates among healthcare providers is significant. And I think we have to acknowledge that. And again, as part of what we have to advocate for is being sure that systems are taking care of all of our patients, but also taking care of us as healthcare providers.
Thank you, great. How do we maintain good mental health when we're worried about the shortage of PPE? And what coping strategies would you give if we're worried we have been infected?
Yeah, I think that shortage of resources, primarily PPEs, but all sorts of resources, is something that we've all been grappling with. And, you know, the mask I got, you know, at this point, probably 3 weeks ago, is not one I should still be wearing in 3 weeks. And every time I see it, it looks a little worse for wear. It smells a little worse for wear. And I begin to wonder, okay, how much protection do I actually get from this? And I can advocate all I want, but resources are resources. I think in the longer run, what we've learned as physicians is that is there going to be a role for us longer term in really pushing our systems to be better prepared for the next time, or better prepared for the long term. At this point, though, that's not we're in the short term. So again, advocating as best we can. I'm amazed at how resourceful healthcare providers have been, and reusing equipment, and taking things that we didn't even think were equipment and turning them into equipment. Things we shouldn't have to be doing, but we clearly are doing. And I think giving ourselves credit for the resourcefulness that we have shown, and continuing to take care of patients when we know there's a better way to do it, but we're not given the resources to do that, so we're doing it anyway. And I think taking some pride and acknowledgement of what we're doing it anyway. I'm not sure I answered your full question, but that was my immediate response.
Yeah, that's great. Thank you. And thank you for this presentation. It was very informative, and I think a lot of good information came out of it. Before we close up, though, I wanted to ask you if you had any final thoughts that you wanted to share.
Well, I think I was kind of getting to it right there at the end. I think I want us all to acknowledge that this really is an extraordinary time, and this is many of us have difficult jobs every day, and this is extraordinarily different than that. I don't know that I've ever worked to the degree that I'm working now, or certainly not in the same way. And I'm not working in ICUs. I'm not at the same level many of you all may be facing. So acknowledging that this is an extraordinary time, and acknowledging that it's okay to take care of ourselves. None of us are selfish, so if we take a few minutes here or there, we shouldn't get down on ourselves for not doing enough. There are few physicians who neglect their duties. That's not what we're doing. Again, this is something that we have to stay in for the longer term, and taking care of ourselves right now is a way that we can take care of our patients tomorrow. And it's okay to give ourselves permission to do that. Again, I want to thank you for inviting me to be part of this. You all know better than I, but I think there's a WhatsApp capability to have some communication in coming days, and I'm happy to participate in that. And again, I wish you all well, and thank you for listening to me over this last hour.
Thank you so much, Dr. Stovall. That was wonderful. And I think those final words about reminding all of these brave healthcare workers to take care of themselves is such an important point, because without them, all of the other sick people are not going to have anyone to take care of them. So thank you for those wonderful words and very relevant presentation. I'm going to turn it over to Claire, because we do want to keep this conversation going and be able to support all of you throughout the weeks and months. And Claire will share about how to join the WhatsApp group.
Yes, thank you again to Dr. Stovall for this presentation and all of your wonderful advice. So we have a WhatsApp chat group for the series. You can join the group by scanning this QR code. We'll also send out a link to join the group in the email if we have your email. We are reaching the point where our WhatsApp group is almost full. So if you're not able to join the group, you can always email us with questions that you have at echo@assisinternational.org, and we'll try to answer your questions. We'll also be sharing the video recording of today's session, and we'll be sharing the slides that have all of the great resources that Dr. Stovall shares. We'll be posting that on our websites, sharing that in the WhatsApp group, and also sending it out via email. Thanks.